Um, Seeing that most of you are already seem to be poisoned with all the, academic feast today, isn't it? Overdose ho gayi hai sabko. So, we'll start with approach to poisoning. What should be the general approach to poisoning, especially when the patient comes to emergency, fine? And our objectives will be that by the end of the lecture, we should be able to describe like what should be our approach to assess the patient, how to resuscitate and stabilize the patient when a patient comes with suspected poisoning, and what should be the physical findings, physical examination findings. Just a minute. What should be the physical examination finding associated with various toxidromes and the antidotes and treatment required for poisonings along with the indication, fine? So what do you think, like what is poisoning actually? Anybody, any takes on that? Okay, poisoning is actually any illness or any unwanted side effects which is caused by exposure to any toxic substance. Toxic kab pata chalta hai? When we get any untoward like signs, symptoms. So why not call out only like having exposure to any toxic substance? Exposure means that you may not have the unwanted side effects. So we call it poisoning only when a patient has illness caused by the exposure, fine? And it can be mostly when a patient presents, most of the time it is with any overdose or any exposure to any recreational drug, something gone wrong, any alcohol intoxication, or sometimes it may be like occupational exposure, like with pesticides. And then it can be environmental exposure. Patient may do this with the intention of deliberate self-harm, like suicidal attempts, or accidental ingestion, like we often see in the pediatric age group. Often जैसे इंडिया में है ना, वो खाली डिब्बा तो फेंकना ही नहीं है, तो उसमें कुछ भी स्टोर करके रख देंगे, तो उसके बाद वो बच्चा क्रॉल करता हो जाता है और उसको खा लेता है, ठीक है? So true incidence is unknown, but then it is the very common cause of emergency department visit. Fine. And why it is so important for emergency department? Because we are the first contact with hospital for anybody making an unwanted visit to hospital. Wanted भी आते हैं, भाई लोग एम्स घूमने भी आते हैं, ठीक है? 28-year-old man found on a ground in a field, brought to emergency because he was unresponsive, he had white powder on his face and clothing, and he started vomiting during the examination. So, if it would have been apart from the seniors in the front, filled auditorium, I would have liked to ask you about your approach and assessment and the management of this patient. Well, to proceed further, anybody who passed along with me, they would say, ma'am, we will go in for GI decontamination with nasogastric lavage and activated charcoal, whole bowel irrigations, optimize the supportive care. So, do you all agree with me? Pardon? Pardon, sir? So partially you're right, but I still disagree with that. Fine. So my objectives, as you said, it is part of resuscitation, prevention of further exposure, enhanced elimination, and then antidote therapy. But for initial stabilization, what do we do? My first thing would be to talk about ABC. भाई ग्रेजुएट हो गए, पोस्ट ग्रेजुएशन कर ली, अपनी अपनी प्रैक्टिस आरंभ कर दी, तो अभी भी बातें हम लोग ABC करते हैं, ठीक है? So my first take on that would be to check with the airway. First thing to check for any patient would be to see for the patency of airway, whether the patient is able to maintain the patency, whether the saturation is being maintained. अगर नहीं हो रही patency, तो my first duty is to secure the airway and see that it is in the right place. Fine. Support the breathing of the patient and then start with the, at the same time, I have to start with, take with the IV exits, start with the fluids support the circulation and the hemodynamics, then check for the disability of the patient, perform the neurological survey, and the mandate under everything is all this has to be done in parallel, not in series. Nothing in medical, हम लोग याद करने के लिए जो भी करें, nothing is done in series. ऐसा नहीं है एक चीज़ करेंगे, ये खत्म हो जाएगी तभी दूसरी चीज़ करेंगे. Of course we work as a team in emergency, so everything has to be done in continuation, and never forget to check the glucose of any of the patients. ठीक है, so now we again come back to the previous one. So now we consider the GI decontamination along with, we optimize the supportive care, and we administer the available antidote. So how do you decide which antidote has to be given? How should we support it? ABCD तो कर लिया, उसके आगे क्या? We very well know, we put on our thinking caps, after all we studied so much, Satoskar, Tripathi, सब कुछ तो पढ़ लिया था, उसमें से कुछ ना कुछ तो निकाल ही लेंगे, कहीं ना कहीं तो उसको फिट कर देंगे और एंटीडोट भी दे देंगे. Does it seem to be that easy? If it was that easy, Miss Rawling would not have been writing about sorting hats. We remember the approach taken by the sorting hat. Okay, they put the sorting hat on the new child. The sorting hat used to say, okay, you are brave, you can think about, so I put you in Greyfinder or I put you on in Slytherin. Similarly, we think about, we put a sorting hat and we named our sorting hat toxidromes. So toxidromes is basically the clinical signs and symptoms associated with different classes of toxin, fine? And it is mostly based on the autonomic effects. We rely on the observable findings like what about the eyes, skin, secretions, and vital signs. And this allows us a rapid narrowing of the differentials. So these are the traditional toxidromes we use: sympathomimetic, anticholinergics, cholinergics, sedative hypnotics, and the opioids. So for sympathomimetics, just to make it easy, we made it into a tabular form. The heart rate becomes fast, it increases, blood pressure becomes high, the cardiac rhythm changes, most often we have tachyarrhythmias, then the respiratory rate and temperature, it may be normal or it may increase. Eyes becomes mydriatic, skin is like diaphoretic mostly or normal, then secretion may be normal, fine? And similarly for anticholinergic, there's unopposed sympathetic tone and there's loss of cholinergic innervation. So heart rate, blood pressure, cardiac rhythm, this may all increase, becomes fast. Respiratory rate may become remain normal. Temperature becomes high and eyes become mydriatic with drying of skin and secretions. And the mnemonic is, I mean, this was my favorite mnemonic. कुछ और याद आए नहीं आए anticholinergic, ये तो हमेशा याद रहता था. Mad as a hatter, blind as a bat, red as a beet, hot as a hair, and dry as a bone. ठीक है? And which drug we use to remember all this? Atropine. And you all know why it is known as atropine. It was derived from the plant Atropa, Atropa belladonna. And belladonna, पता है उसे क्यों पाला गया था? It was used in the earlier times by the ballerinas to give that beautiful eyes look, wide open. Cholinergic toxidrome. Now it is heart rate becomes slow, blood pressure becomes low or normal, cardiac rhythm becomes bready, respiratory rate becomes less, temperature may become less, eyes become miotic, totally opposite. Skin is like diaphoretic, secretions are copious. सबसे बड़ी problem, especially in agrarian society like ours. And these are the mnemonics, sludge and dumbbells. किस में देखते हैं हम सबसे ज़्यादा? Organophosphorus poisoning में, when they come. Then is a sedative hypnotic. इसमें और कुछ, like you may not remember the mnemonic, nothing. Just remember that it is just pouring out from everywhere, all orifice. Sedative hypnotics. Sedation is the primary hallmark. And patient is like sleepy, drowsy. Patient may not be able to protect their airway, especially in severe cases. They may be having respiratory depression, but there may be minimal autonomic effects. And there may be some symptoms which we may not be able to explain because of the co-ingestion. Sedative na mostly akele nahi milte. They are mostly like in a combination of drugs. Then is the opioids. Mostly there is meiosis, and respiratory depression is very common, and if not taken care of at the same time, it may prove to be fatal. So we do a review. We have just tried to summarize all the toxidromes. Fine. The sympathetic, if we see at a glance, if we want to check them, what is the difference? It has been presented in a like tabular form together. And then we go on to remember this to the first case we were talked about, a 28-year-old man who was brought to emergency, who was unresponsive, who was found on the ground in the field, and he had white powder, and he began vomiting. So now his vital signs, temperature is like slightly low, heart rate is low, respiratory rate is like fine, BP is fine, saturation is less, and gurgling respirations with pool secretion, that means, and pupils are like 1 millimeter with skin cool and diaphoretic. And so what do we say? I mean, the age got changed while making the slides, but it is the same person. So what do we say? Gurgling respirations with pooled secretions. That means secretions everywhere, isn't it? Pupils 1 millimeter, okay? So it is like bodily fluids were everywhere, cholinergics, and most of the cholinergic exposures are from pesticides. Let's talk about our area, organophosphates. So our management will be, apart from the airway, breathing, and circulation. Okay, we'll talk about the decontamination here for D, and prevent further exposure for patient and for you. Okay? And of course, we talked about that we have to go in for early intubation. Then management would be further for high flow oxygen with positive pressure, and antidote would be atropine and pralidoxim. Now, pralidoxim, though it is only suggested nowadays, but it still has to be, it is there in the management part, it has to be continued for the first 3 to 7 days. Second case is about the bottle found on a bed. A 38-year-old man was found unresponsive in the bedroom by the family. And they saw, while they just got him to bring him to the hospital, they saw an empty pill bottle on his bed, but they did not bring it with them. So, and what do you suspect? Well, pill bottle padi thi, to koi na koi to drug exposure hua. So now the pupils are like constricted, skin is cyanotic but dry, and if we see, the main thing here is respiratory rate is 4 and saturation is very less. So that means patient has respiratory depression. The first and fourth thing that comes to my mind after seeing this patient as per toxidrome is opioid poisoning. See, the pupils were pinpoint, respiratory depression was there. Now exposure may have been recreational. Okay, kuch na kuch to tha na, he was found in his bedroom. Management would be again, support the respiration, airway and breathing. Okay, so patient may need intubation, especially because he did not, who don't rapidly respond to the treatment and restore the oxygenation. Antidote would be naloxone and opioid receptor, because it's an opioid receptor antagonist, and dose required is variable. Now it's a very short acting naloxone. So like once you verify, you may have to start with infusion, or you may start the patient on artificial ventilation with the help of ventilator. So slowly the effect will wear off, and then you can extubate your patient. So the learning objective for today are, like we are able to describe an approach based on the toxidromes for the assessment, stabilization, and we have described about the physical findings associated and the list of antidotes and treatment. So essential principles would be, use the knowledge of toxidromes to narrow the differential. It is not possible to remember the thousands of drugs we know. Abhi hota kya hai? Likhiye. Let us associate with religion as we are all primed to do. 33 करोड़ देवी देवता हैं. आपको कितनों के नाम याद हैं? जब कोई मुसीबत पड़ती है तो मैं तो सबसे पहले ऐसे याद कर लेती हूँ, ब्रह्मा विष्णु महेश हनुमान जी, बस हो गया जी. अब 33 करोड़ कौन याद रखेगा? सभी में सार आ गया ना, तो ये 5 टॉक्सीड्रोम याद कर लो, काफ़ी कुछ तो निकल ही जाएगा. बाकी तो ठीक है, गूगल बाबा हमेशा है. ठीक है. Externally decontaminate your patient to protect yourself and them. Aggressive support with, always remember ABCD. प्राइमरी में पढ़ा हुआ कभी खाली नहीं जाता, ठीक है, और छोटी एज में पढ़ा था तो याद भी रहता है, अभी वाली चीज़ें तो शॉर्ट टर्म मेमोरी में ही जाती हैं. Consider DI decontamination, GI decontamination, give antidotes wherever available and indicated, and try to enhance the elimination. So, अभी इतना करने के बाद आई होप यू ऑल आर डाउन विद द पावर पॉट पॉइजनिंग, और उसका तो कोई मेरे पास एंटीडोट भी नहीं है सजेस्ट करने के लिए. सो एनी क्वेश्चंस ऑन दैट?
Thank you, madam. I must congratulate on your excellent lecture and moreover, your personality. You are the most, you can say, adjusting speaker that you offered. That tell me 7 days before, because there was lot of queries from other speakers कि हमको यहाँ पे time adjust कर दो, यहाँ के पे कर दो. So I am really grateful to you for your flexibility and helping us out to allot these slots to the speaker. And I want to make you permanent faculty for MAPICON for next 5 years. उसके बाद का तो हमको पता नहीं है, पर we are really grateful to you for your flexibility and your offer. So it is really great. Thank you very much.
Thank you, sir, for the honor.